we are revising integrated systems. In the endocrine part, we have a bit of physiology, but we will focus on first diabetes, diabetic ketoacidosis, HHS. What is the difference? What are the IAD PhD guidelines that was asked and that will be asked? Oral hypoglycemic agents, okay. Some GnRH, agonist, antagonist. In anterior pituitary, prolactinoma and Sheehan syndrome, integrated questions with obs and gynecology. Then acromegaly. We have Cushing syndrome, the test investigation of choice, and it is low dexamethasone. Then posterior pituitary disorders, central diabetes insipidus, syndrome of inappropriate ADH secretion, then nephrogenic DI. Okay. Very importantly, the approach to PTH and the calcium metabolism disorders have been a question. Okay. Vitamin D, then in primary hyperparathyroidism, what happens in secondary hyperparathyroidism. Okay. Treatment of osteoporosis. Yes, treatment of osteoporosis. Then we have a simple diagram of flow chart of how the thyroid hormone works, like this. Okay. So thyroid physiology and the management of thyroid storm. The first line that you give is obviously beta blockers, propylthiouracil, glucocorticoids, and sodium iodide. Okay. Why first beta blockers? It will decrease the heart rate and also inhibits the peripheral conversion. Very good. It inhibits the peripheral conversion. Okay. Okay. In PYQs, what is the PYQ? They love to ask you about that. In asthmatic patient, we have to use calcium channel blockers, not beta blockers. Okay. Preferably, we'll use the verapamil. Okay. In myxedemic coma, which is severe hypothyroidism, there is hypothermia, history of hypothermia. We put hypothermia first. Intravenous T3 plus or levothyroxine we can give, hydrocot or 0.9% NaCl if the sodium is also low. So in myxedemic coma, we'll treat hypothermia with hypothermia, intravenous drugs, and we will give T3 or levothyroxine, IV hydrocot, and 0.9% of NaCl. Okay, that was your thyroid. Okay. Adrenal insufficiency, they can ask about investigation of choice. They can ask about to identify the case, then to treat, how to treat. Okay, how to treat the case. Then we have hyperaldosterone. Now hyperaldosterone is nothing but your Conn syndrome. We will study Conn syndrome. Okay, Conn syndrome, just the basics and how to diagnose. And then in the last we have pheochromocytoma. Almost every year there is a question on pheochromocytoma. Like there was a question in which there was a triad of clinical features which was there. Okay, so the options were persistent headache, sweating, palpitations. Okay, what is the one which is not a feature of pheochromocytoma? It is persistent headache, sweating, palpitations. What in which of the following is not a feature of pheochromocytoma? It is persistent headache, because there is episodic headache in pheochromocytoma, not persistent, plus there is sweating and palpitation. Most common symptom being headache, most common sign being hypertension. Initial investigation, when the patient comes to you with all of these features, initial investigation being urinary metanephrin, VMA, which is basically elevated. Confirm it by plasma. First you do the urinary test, then to confirm it you do a plasma test. Best to localize it, do an MRI. Biopsy and FNAC is contraindicated, and best for metastasis is MIBG scan. What is the best for extra-adrenal? Now this can be a question that can be asked. Extra-adrenal pheochromocytoma, technetium-99 DOPA PET scan is the investigation. Okay. Most common site for extra-adrenal PCC is organ of Zucker candle. What is the treatment? Very, very important question. First, we do the alpha blockade. First we do the alpha blockade, followed by beta blockade, followed by the surgery. ठीक है. In intra-op, what will we do in the intra-op management? Intra-op management of hypertension in pheochromocytoma, we use nicardipine. Okay, so we use CCBs like nicardipine, nitroprusside, and IV phentolamine. We see a light bulb sign in T2, which is hyperintense, a Zell-Ballen pattern, histopathology. Rule of 10 applies in the pheochromocytoma. 10% are extrarenal. Very good. 10% are extrarenal. 10% has no hypertension. 10% occurs in children, and 10% are bilateral. So only 10% are bilateral. ठीक है. Most of the tumor are unilateral, but 50% are syndromic, है ना, malignant. Only the 10% of pheochromocytoma are malignant. Only the 10% of pheochromocytoma, these are familial. Okay, this has been associated. PCC are associated with MEN 2A, 2B, VHL, NF1, and SDH. ठीक है. Okay, now we will go for the DKA, which is diabetic ketoacidosis and diabetes in general. How to diagnose diabetes mellitus? How to screen, first of all, how to screen? Yes, so there are 4 factors: HbA1c, FBS, RBS, and OGTT. HbA1c, we already know the normal is the normal is less than 5.7. More than 6.5 is again diabetic. FBS 100 to 126, it is pre-diabetic range or impaired glucose tolerance. More than 126 is for diabetes. RBS and OGTT, more than 200 is what qualifies for DM, and 140 to 200 is IGT, impaired glucose tolerance again. Okay, if we talk about the structure of insulin, it derives from proinsulin. ठीक है, and proinsulin derives from pre-proinsulin. So there is this removal of C, and what you see, it is a mature insulin. So mature insulin does not have a C peptide. When there is a removal of C peptide, ठीक है, that's how you form the insulin. ठीक है, it has 51 amino acids, and it's secreted by the beta cells of the pancreas. Okay, alpha cells of pancreas release glucagon, and the delta cells release the somatostatin. Very good. Talking about type 1 and type 2 diabetes mellitus, and there are some special type of diabetes mellitus like Modi, which is an autosomal dominant. Modi is nothing but maturity onset diabetes of the young. It has a strong familial inheritance. So MODY, if there is young with diabetes mellitus, we have to think of Modi. Right, so less than 25 years, more than two there in the family member, right, and everything is normal. The insulin levels are normal or decreased, B cell mass is decreased, so OHG can be used. Patient of diabetes type 1 or type 2 can present with DKA, but MODY will never present with DKA because there are no antibodies. It is a monogenic diabetes. Okay, but type 1 diabetes mellitus mein the main issue is it is autoimmune. So there are antibodies like anti-islet and anti-GAD antibodies which are there. Adult onset, which is LADA. Also there is antibodies against insulin itself, so anti-insulin, and there is zinc. Okay, age of onset, it is childhood. Habitus is thin. Decreased insulin levels. OHGs, there is no use. PYQ. What was the PYQ? The PYQ was in type 1 diabetes mellitus. In histopathology, you see there is leukocytic infiltration, and you treat them by insulin. Type 1 diabetes, the drug of choice is insulin. Type 2 diabetes mellitus, oral hypoglycemic agents. Okay? Type 2 diabetes mellitus, again more common in adult. Obese, insulin levels can be increased or can be decreased. It can be used. Okay? Histopathology shows amyloid in type 2. Type 1.5 diabetes mellitus, it is also called as LADA, latent autoimmune diabetes of adults. Okay? There is a biphasic release of insulin, which is there. There is a biphasic release of insulin. First spike when with the preformed insulin, and the second spike for the slow sustained peak of insulin. The renal threshold for glucose is 180. After 180, there would be glucosuria. Type 1 diabetes mellitus, it was a PYQ. It is divided into 3 stages, stage 1, 2, and 3. The 1 is your antibodies plus no symptom. Second, antibodies plus dysglycemia plus no symptom. But third stage is you have antibody plus there is a hyperglycemia plus symptom plus there is severe beta cell destruction. Okay, severe beta cell destruction. Okay. Leptin in the adipocytes decrease the insulin. Leptin in the adipocyte decrease the insulin. Okay. In somatostatin also decreases the insulin. ठीक है. Okay. Metabolic syndrome. The things we need to remember: central obesity. Okay. Elevated triglycerides more than 150, HDL, right? Blood pressure, which is more, and there is fasting glucose, which is elevated. This is metabolic syndrome. LDL is not included in metabolic syndrome. LDL is not included in metabolic syndrome. Okay. There is Dawn and Somogi phenomena. Yes, Dawn phenomena, there is increase in blood glucose. Yes, the treatment is continuous glucose monitoring. In Somogi, it is so much, so insulin at the bedtime. Okay, it is due to the excess overnight insulin. So there is so much insulin, and it is due to insulin that there is overnight hypoglycemia in Somogi phenomena. Types of insulin, we have a lots to study. Types of insulin: ultra short acting insulin like Lispro, Aspart, Clolazine. We have regular insulin, which is given IV. It is short acting insulin, 2 to 3 hours. Intermediate acting insulin like NPH and Lente insulin, which is 4 to 6 hours. Degludec, it is longest acting insulin, 42 hours. Yes. Apart from Degludec, what are the other long acting insulins? It is Detamir and Glargine. Okay. What are the side effects of insulin? It is lipodystrophy, hypokalemia, very important. Hypokalemia, lipodystrophy, weight gain, and even hypoglycemia. Frezin is an inhalational insulin. Yes, good glycemic control can reduce microvascular complications like DR, DN, and DN. Most common microvascular complication in diabetes mellitus is neuropathy, not nephropathy, it is neuropathy. Most common type is glove and stocking pattern. Yes. Drugs that can cause diabetes mellitus are steroids, right? They always steroids, yes. So steroids also can cause. So steroids, thiazides, niacin, phenytoin, right? Phenytoins can also predispose to diabetes mellitus. Clozapine, beta agonist, and IFN alpha. Most common cause of death because of DM is due to cardiovascular complications. It was in PYQ. So acute myocardial infarction is the answer. Non-diabetic patient comes to you with abdominal pain, nausea, vomiting. Okay, and there is ketonuria. What do you suspect? It's nothing but your diabetes ketoacidosis. Okay, so glucose, there are four things which we need to determine in diabetes ketoacidosis. First is the glucose levels, 250, more than 250 gram per deciliter, which is your glucose levels. ABG, so what is the pH? pH should be less than, it should be acidic pH, right? No. Hegma, which is your high acidic high anion gap metabolic acidosis. Fruity odor, type 1 DM, right? And the pathophysiology is basically illness plus there is some stressor which triggers. Okay, first we start for IV fluids and then we go for insulin. That is the most easiest management. Okay, IV fluid followed by IV insulin, then there is KCL if KPAS is less, and then there is bicarb. So IV fluid first followed by insulin. Yes, there is also something called as euglycemic diabetes ketoacidosis. Yes, in which we have diabetes, which is diabetic ketoacidosis, which is occurring due to stress or any illness, so it is less than 250, but we generally give SGLT2 inhibitors. Yes, so SGLT2 inhibitors can cause euglycemic diabetes ketoacidosis. Okay. If the patient is in shock, if the DK patient is in shock, first what you have to do is resuscitate the patient, and IV fluids you can give, insulin you can give. First do the airway management, then do the breathing, and then just go on with the management. Not in shock, first do the saline, 10 to 20 ml per kg, right, 0.9% over 30 minutes. Then carry the fluid deficit over 1 to 2 days. Add potassium, take, and continuous IV insulin infusion. And a regular insulin you will give at 0.1 minutes per kg per hour. For a child with DKA, pH is less, RBS is raised, right? You have a regimen of 20 ml per kg of NS over 20 minutes, followed by insulin infusion, followed by KCL, which is 40 milliequivalents per liter. So for child, 20 ml per kg NS over 20 minutes, followed by insulin. Okay, we do a 10% deficit correction. 10% deficit correction. Okay. We have oral hypoglycemic agents. If we talk about which one reduces the mortality at the max, it is SGLT2 inhibitors, right? Which is dapagliflozin, campagliflozin. Okay. Sulfonylureas and meglitinides. Sulfonylurea, all the IDE drugs, chlorpropionamide, glipizide, gliburide, repaglinide, netiglinide. Right? Mechanism of action: increases insulin secretion. Right? Right? What was the PYQ? Previous question says that the sulfonylureas, they increase the serum C peptide. Yes, they will increase insulin secretion. They will definitely increase the serum C peptide. Okay. What are the side effects? Weight gain. More insulin, more the weight. Definitely hypoglycemia and weight gain also. Glipizide. PYQ, glipizide is safe in renal failure. Correct. What are the two side effects? Two side effects are SIADH and cholestatic jaundice. Okay. IDE drugs of diabetes. What are the side effects? Cholestatic jaundice, SIADH. Glipizide is safe in renal failure. Metformin, the OG drug of diabetes. It is a first-line drug. How does it act? It stimulates the AMP kinase. It decreases the resistance. It does not help in increasing the insulin, but it decreases the resistance to the insulin. That's why it is preferred in type 2 diabetes mellitus. Very useful in decreasing the risk mortality. Okay, so we will definitely prefer the biguanides and SGLT2 in case of MI, in case of angina, in case of stroke, in case of atherosclerosis. Okay. Side effects. What are the side effects? Side effects are lactic acidosis, weight loss, vitamin B12 deficiency. We can have an integrated question regarding lactic acidosis, metformin, vitamin B12 deficiency, diarrhea. That was what came in the PYQ. So metformin is a biguanide, right? And it stimulates AMP kinase. It decreases the insulin resistance, causes lactic acidosis, diarrhea, weight loss, B12 deficiency. Maximum reduction in HbA1c as well, but it is contraindicated in renal failure because the main excretion organ of metformin is kidneys. It is contraindicated in renal failure. Thiazolidine with pioglitazone and rosiglitazone. Okay. Again, PPARG में they regulate the PPARG. Weight gain, heart failure. Yes, side effects of pioglitazone. Weight gain, heart failure, hepatotoxic. Yes, thiazolidine or pioglitazone are hepatotoxic. They also cause cystoid macular edema. Risk of bladder cancer is also more. Okay, MI में you can use MI में. So rosiglitazone has the risk of MI. Yes, so it is not a first line drug. Pioglitazone no, rosiglitazone nahi. Weight gain, heart failure, hepatotoxic. ठीक है, even MI it can cause risk of bladder cancer and also there. ठीक है, so pioglitazone, rosiglitazone is not given. GLP-1 agonist. ठीक है, a very famous drug semaglutide, which is Ozempic. It is given oral or subcutaneous. Exenatide, liraglutide, tirzepatide, and semaglutide. Semaglutide can be given oral, subcutaneous. Tirzepatide is definitely subcute. Okay. It increases the glucose-dependent insulin secretion. Yes, and decreases the glucagon secretion. Also, very important, why does it help in weight loss? Because it delays gastric emptying. And that's how it helps in weight loss and increases satiety. Also, they have a major side effect of pancreatitis and medullary thyroid cancer. What is the MCQ? GLP-1 agonist like tirzepatide, ठीक है, like semaglutide, ठीक है, like exenatide, ठीक है, they are safe in renal failure, but they can cause pancreatitis. Yes, they can cause MTC, ठीक है. Okay, exenatide is not safe in renal failure, ठीक है. Exenatide, it is not safe. Every GLP-1 analog is safe in renal failure except it is exenatide, which is not safe in renal failure. DPP-4 inhibitors are taken oral, which are weight neutral drugs like sitagliptin, sexagliptin, linagliptin. Okay, now they are contraindicated in renal failure. DPP-4 are contraindicated. So two drugs which we studied which are contraindicated in renal failure. One is metformin. ठीक है, one is metformin. Second is DPP-4 inhibitors. Third is exenatide. Okay, ठीक है. So in the group of DPP-4 inhibitors, the only drug that you can use for renal failure is linagliptin. ठीक है. Okay, pramlintide is there, and there is acarbose and miglitol. Acarbose has nothing but it is contraindicated in IBD, diarrhea it can cause. Very good. Very important is SGLT2 inhibitors. So SGLT2 inhibitors, canagliflozin, dapagliflozin, sotagliflozin, these are the drug of choice in DM with heart HF/REF. Yes, SGLT2 inhibitors are their drug of choice for reduced ejection fraction heart failure. It increases the renal glucose excretion. Kidney से glucose excretion करवाता है. It is useful in cardiovascular risk mortality. Yes. But what are the side effects? UTI, polyuria. They asked about fractures. Correct? They asked about fractures. Also, candidiasis, phoneal gangrene they can cause. And they can cause euglycemic ketoacidosis. Very good. So, SGLT2 inhibitors should be stopped 2 to 3 days prior to the surgery. SGLT2 inhibitors. Now, SGLT2 inhibitors are drug of choice for DM plus HF/REF, but they can cause UTI, they can cause polyuria, they can cause fractures, they can cause weight loss, candidiasis, and phoneal gangrene. Okay. We learnt about tirzepatide, which was subcute drug. which was GL1 plus GIP agonist, it can cause maximum weight loss. A question, ठीक है. Injection Monjaro, it is terzepatide, will cause maximum weight loss. Okay. Sexagliptin is basically CYP metabolized. Okay. Drug which are contraindicated in renal failure. Okay. We just study metformin and DPP4 inhibitors except Lena. Okay. All right. UTI. The risk of UTI is there in SGLT2 inhibitors like dapagliflozin. Acha. What are the two twin hormones in pituitary? It is GH and prolactin. A question. Because they are both produced by the acidophilic part of the pituitary. Okay. Dopamine inhibits prolactin. Okay. Now let's talk about some drugs. Some drugs which are also important in yes, obs and gynae. What are some GnRH agonists which are continuous? ठीक है. So these are goserelin, ठीक है. Goserelin. You should not forget goserelin and leuprolide. These are used in fibroid, yes, endometriosis, CA breast, and precocious puberty. ठीक है. We need to decrease the estrogenic levels here. But in the case of delayed puberty, we need to increase. ठीक है. And we will give a pulsatile GnRH agonist. Okay. What are antagonists with the X, they end with X? Ganirelix, cetrorelix. What are GHRH analog, growth hormone, releasing hormone analog? These are tesamorelin. These are associated with HIV-associated lipodystrophy. Yes. PYQ. Tesamorelin. They are associated with HIV-associated lipodystrophy. Okay. ठीक है. Patient with amenorrhea, infertility, galactoria. Galactoria is basically milk-like secretions. And you see there is increased PRL levels. ठीक है. When you do an MRI, you definitely see a tumor. Okay. What is the diagnosis? Prolactinoma. PRL more than 200. You have to rule out hypothyroidism, renal failure, pregnancy. So first step, you should go with doing a UPT, RFT, and TSH. UPT, RFT, and TSH. So rule out other things. Yes. No. You will do for diagnosis of the condition. You will do an contrast enhanced MRI, which will show you a tumor. Okay. Microadenoma is less than 10 meters, which is hyperfunctioning. Macroadenoma is more than 10. Investigation is MRI pituitary or MRI sella contrast, which is enhanced. Okay. Yes, as they have come to you with infertility, amenorrhea, estrogen कम, progesterone कम, ठीक है, GnRH is also कम, infertility हो चुकी है, amenorrhea है, you will do something. Okay, you will give cabergoline is a dopamine agonist. ठीक है. Dopamine inhibits the production of prolactin. When you inhibit dopamine, prolactin would increase, right? No. It also suppresses lactation. ठीक है. In pregnancy, prolactinoma, again a question. Very, very important MCQ. In case of pregnancy plus prolactinoma, the drug of choice is bromocriptine. Okay. Surgery you will do for macroadenoma. Okay. Side effects are valvular fibrosis. Okay. Postpartum patient coming to you with amenorrhea, right? Failure to lactate. Okay. MRI, you see there is empty cella. The diagnosis is Sheehan syndrome, which is basically ischemic necrosis of pituitary following a postpartum hemorrhage. Postpartum hemorrhage. You do confirmatory test for by insulin tolerance test. A heighted person coming to you with coarse faces, protruded jaw, right? And there is heel pad thickening which is there, prognathism which is there, okay? And in X-ray you see there is a spade-like phalanx. There is a spade-like phalanx. What is the diagnosis? It is acromegaly. Acromegaly is basically nothing but increase in growth hormone. Initially you will do an insulin growth factor initially, but confirmatory you will do OGTT-GH. Okay, management is by surgery. Pegvisomart, it is a GH receptor antagonist. Okay. Sudden headache, visual deficits, the patient is in shock, and she has a history of pre-existing adenoma. What do you think of? The patient is in shock right now, and there is a history of pre-existing adenoma. It is nothing but pituitary apoplexy. The T1 weight MRI show enhancement in the pituitary region. It is the pituitary apoplexy we're talking about. We get is hemorrhage. For Cushing syndrome, the investigation of choice is low dose dexamethasone suppression test. Right? Most common cause is exogenous steroid intake. 1 milligram dexamethasone, it remains high. Okay. Fat pad, bruise easily, purple stria. Okay, if ACTH is low and if ACTH is high. If ACTH is low, we will think of adrenal adenoma. If it is high, pituitary adenoma is 90% chances. We do a high dose DNS, high dose dexamethasone suppression test. Okay, very frequently asked question. Hyperpigmentation plus there is headache. History of bilateral adrenalectomy for Cushing syndrome. It is Nelson syndrome. Okay. Drug of choice for central diabetes insipidus it is desmopressin, where the ADH only is less. Okay? ADH is only less, and uric acid is high. For nephrogenic diabetes insipidus, the uric acid is low. Okay? Urine osmolarity is also low. Thiazide, we use thiazides for nephrogenic diabetes insipidus. Syndrome of inappropriate ADH secretion. They present with euvolemic hyponatremia. Okay. These are the hallmark. We use water loading test for diagnosis and fluid restriction as a management protocol, and we give VAP terms. Small cell lung cancer is associated with SIADH. Causes of nephrogenic DI, very very important, is lithium. We treat it by amiloride. Okay. They asked about familial hypercalcemia, in which there is hypercalcemia but hypocalciuria. Yes, it is an autosomal dominant disorder. Okay. Whenever we talk about thiazides and vitamin A toxicity, there is suppressed PTH and there is hypercalcemia. So hypercalcemia with suppressed PTH, it is thiazides and vitamin A toxicity. Okay. If you talk about rickets or osteomalacia, where there is vitamin D deficiency, calcium is definitely low, phosphate is definitely low, but the PTH is increased in order to compensate. The ALP is also increased. So ALP is increased, PTH is also increased, it is vitamin. Okay. Bisphosphonates cause osteonecrosis of jaw. Image-based question. Atypical femur fracture, even esophagitis. Longest acting. Bisphosphonate is zolindronate, but the side effects is renal failure. Right? So zolindronate, it is the intravenous drug, most potent. It is given annually. अच्छा, हाइपरटेंशन प्लस हाइपोकैलेमिया प्लस एल्केलोसिस, मतलब कि बीपी इज इंक्रीज्ड, हाइपोकैलेमिया एंड एल्केलोसिस. Okay, these are features of many diseases. But if there is decrease in the renin, and increase in the aldosterone, decrease in the renin, increase in the aldosterone. It is only one condition, which is Conn syndrome. So there is adrenal adenoma or hyperplasia. Okay? There is hypokalemia, there is metabolic alkalosis, and there is hypertension. Why? Because there is increase in the blood volume. There is more and more aldosterone which is produced. Okay? If we have decreased renin and decreased aldosterone, along with hypertension, hypokalemia, alkalosis, we think of Liddle syndrome. Liddle syndrome. Okay? Also, in congenital adrenal hyperplasia (CAH), we have 11 or 17 alpha hydroxylase deficiency, in which we have all of these features. Patient which has features like increased serotonin, increased HIAA. Okay, we have Kulchinsky cells, which is the origin, yes, and the appendix is the site, so it is the carcinoid tumor. Carcinoid tumor. Okay, skin flushing, skin flushing, vasospasm, asthma, diarrhea. We have to do a surgery for carcinoid tumor, and if the surgery is not successful, we can start octreotide. Rule of 1/3 is applied for carcinoid tumor. PCC we already did. Rule of 10. Sweating, hypertension, headache, alpha blocker followed by beta blocker. Right? 10% are bilateral. 10% are malignant. Zell-Ballen pattern. Light bulb sign. Okay. Okay, we will do diuretics, we'll do RTA, deposit के main graphs, nephrotic syndrome. Okay, then AKI CKD, in which they are asking about your grades of CKD. CKD can be asked, grades of AKI can be asked, KD को classification. Yes, and then the most important point is about the yes, the acid base imbalance. Simple keywords, simple points, simple formulas, and calculations can give a correct answer.